Welcome, future nursing champions, to today's fast-paced deep dive into pharmacology of the Integumentary System, your one-stop session to decode the skin drugs that matter most for NCLEX success. In this video, you will tackle 15 carefully crafted questions that span everything from high-potency steroids and calcineurin inhibitors to burn antimicrobials, antifungal nail therapies, antivirals, scabies remedies, and lidocaine patches, complete with test-ready rationales that sharpen clinical judgment. We drop high-yield, exam-focused nursing content like this every single day, so watch to the very end, hit follow, and make our daily videos your go-to boost on the journey from diligent student to confident licensed nurse. Before today's question, here's something you need to hear. Your NCLEX success could start right here. Our complete NCLEX review online course includes 100 hours of engaging animations, 500 hours of focused lectures, 5,000 high-yield questions, 500 NGN case studies, and 15 CAT-style exams. You'll also receive a full NCLEX ebook, valid for 12 months, and for now, it's available at 70% off. Thousands have already made it. Now it's your turn. Visit the website link in the description. Sweeping right into our very first clinical challenge, let us kick things off with a fresh spark. Here comes question 1. Listen closely, because this scenario could pop up in your NCLEX and in real life. A 35-year-old client with newly diagnosed bipolar disorder is being discharged with several prescriptions. Which ordered medication should alert the nurse to the greatest risk for developing Stevens-Johnson syndrome and therefore requires the most rigorous skin assessment teaching? Now, shift your focus as we roll smoothly into the possibilities. Option A, escitalopram. Option B, atomoxetine. Option C, amlodipine. Option D, lamotrigine. Take a second to weigh those choices because the answer that shines a warning light is option D, lamotrigine. Here is why, and stay with me as we unpack this step by step. Lamotrigine, an anticonvulsant that also serves as a mood stabilizer for bipolar disorder, carries a black box alert for life-threatening mucocutaneous reactions such as Stevens-Johnson syndrome and toxic epidermal necrolysis. Early influenza-like symptoms can escalate quickly into blistering or sloughing of the skin and oral mucosa, so strict dose escalation schedules, prompt drug discontinuation at the first hint of a rash, and crystal-clear teaching about urgent reporting are absolutely critical. By comparison, escitalopram is a selective serotonin reuptake inhibitor, primarily linked with serotonin syndrome rather than severe cutaneous reactions, making rigorous skin surveillance a lower priority. Atomoxetine is a selective norepinephrine reuptake inhibitor used for attention deficit and hyperactivity disorder, usually causing gastrointestinal discomfort or hypertension, with no strong correlation to Stevens-Johnson syndrome. Amlodipine, a calcium channel blocker for hypertension or chronic stable angina, is better known for producing peripheral edema or gingival hyperplasia, not for catastrophic skin disorders. Keep these clinical pearls in your toolkit. The medications most frequently implicated in Stevens-Johnson syndrome include specific anticonvulsants such as lamotrigine, phenytoin, and phenobarbital, sulfonamide antibiotics, and allopurinol. Moreover, individuals who carry the human leukocyte antigen subtype B1502, especially prevalent in many Asian populations, face markedly higher danger when exposed to carbamazepine. Above all, teach every client to report any new rash immediately, particularly within the first 8 weeks of therapy, because early withdrawal can be life-saving. Now, fasten your clinical seatbelts with question 2. A client who sustained 27% total body surface area burns, including deep partial thickness and full thickness injuries to the anterior torso and upper extremities, will undergo the first extensive hydrotherapy and dressing change in 20 minutes. 4 analgesic orders are available. Which medication should the nurse give now to achieve the most rapid, titratable control of the anticipated procedural pain? Focus as we line up your choices. Option A, tramadol 100 mg by mouth. Option B, hydromorphone 1 mg intravenous push. Option C, ibuprofen 800 mg by mouth. Option D, pregabalin 150 mg by mouth. Weigh onset, potency, and route, then lock in the drug that can be adjusted moment to moment. Option B, hydromorphone 1 mg intravenous push. Here's the reasoning. Stay tuned while we unpack it together. Intravenous hydromorphone is a potent mu-opioid receptor agonist that peaks in about 5 minutes, bypasses gastrointestinal delays, and can be titrated minute by minute, giving swift and controllable relief for the intense but brief pain of burn debridement and dressing changes. Contrast that with oral tramadol, which must convert to its active metabolite and takes close to 2 hours to peak, providing only moderate relief not suited for the severity of pain. Oral ibuprofen delivers anti-inflammatory benefits and mild to moderate analgesia, but requires 30 to 60 minutes to work and can strain the gastrointestinal tract and kidneys in fluid-shifting burn clients. Pregabalin targets neuropathic pathways and is valuable later for chronic burn pain and opioid sparing. Yet its 90-minute peak and modest acute effect leave it ill-equipped for a procedure about to start. Clinical Pearl, for scheduled burn procedures, intravenous opioids such as morphine, hydromorphone, or fentanyl remain first line because they combine rapid onset, straightforward titration, and predictable duration, while non-opioid adjuncts are layered on afterward to trim total opioid exposure. Always reassess pain and sedation within 5 to 15 minutes because burn physiology can dramatically alter drug distribution and clearance, ensuring each client stays safe and comfortable throughout every step of care. Rolling right along and keeping our diagnostic instincts sharp, here is question 3. During the early morning assessment of a 42-year-old woman with newly diagnosed systemic sclerosis, the nurse notes complaints of finger stiffness and intermittent dysphagia. Which integumentary finding, if present, would most strongly support the underlying pathophysiology of systemic sclerosis? Shift gears and picture each possibility as I lay them out for you. Option A, Heberden nodes at the distal interphalangeal joints. Option B, Kayser-Fleischer rings encircling the cornea. Option C, Osler nodes on the pads of the fingers. Option D, taut, shiny, thickened skin over the forearms. Take a moment to connect pathophysiology with presentation, because the sign that most powerfully confirms systemic sclerosis is option D, taut, shiny, thickened skin over the forearms. Let us unpack that choice in a way that cements it to memory. Systemic sclerosis, also called scleroderma, begins with immune-driven microvascular injury that unleashes overactive fibroblasts to lay down excessive collagen, producing indurated glossy skin that feels board-like. It typically starts in the fingers and hands, then marches proximally to the forearms, face, and trunk, eventually limiting joint motion, creating a mask-like facies, and setting the stage for ischemic digital ulcers. Swinging our spotlight to the distractors, Heberden nodes are hard, bony enlargements at the distal interphalangeal joints caused by osteophyte formation in osteoarthritis. They have nothing to do with autoimmune collagen deposition or vascular dysfunction. Kayser-Fleischer rings are bronze-colored corneal deposits of copper seen in Wilson disease, a genetic disorder leading to hepatic, neurologic, and psychiatric symptoms rather than cutaneous fibrosis. Osler nodes are tender erythematous nodules on finger pads that arise from immune complex vasculitis in infective endocarditis, and usually appear alongside fever and new cardiac murmurs, disappearing once the infection is treated. Tuck away these clinical pearls as we press onward. Rapid progression of skin tightening over the trunk often heralds serious visceral involvement, such as pulmonary fibrosis or renal crisis. Raynaud phenomenon, digital ulcers, telangiectasias, esophageal dysmotility, and pulmonary arterial hypertension commonly accompany the skin changes. Early immunomodulatory therapy, along with meticulous skin and oral care, aggressive reflux control, and firm smoking cessation can slow disease progression and safeguard quality of life. Time to pivot to a case that hits many adolescents hard and often lingers into early adulthood, with question 4. A 19-year-old client presents with painful nodulocystic acne covering more than 40% of the face and upper trunk. Previous therapies have included 8 weeks of benzoyl peroxide plus topical clindamycin and 6 months of oral doxycycline with only minimal improvement. The client voices significant psychosocial distress and requests the strongest treatment available. Based on the history and severity, which medication should the nurse anticipate the primary healthcare provider will prescribe next? Let us line up the contenders so you can weigh their strengths and weaknesses. Option A, valacyclovir. Option B, terbinafine. Option C, isotretinoin. Option D, rifampin. Pause for a moment and match each drug to the multifactorial roots of acne: excess sebum, follicular plugging, bacterial proliferation, and inflammation. Because the therapy that checks every box is option C, isotretinoin. Here is the expanded reasoning, delivered step by step so you can feel confident explaining it at the bedside or on the NCLEX. First, isotretinoin is an oral systemic retinoid that shrinks sebaceous gland volume, slashes sebum production, normalizes the way keratinocytes shed inside follicles, and dampens inflammatory signaling by downregulating toll-like receptor 2 on immune cells. Those combined actions strike at all four pillars of acne pathogenesis, which is why a cumulative dose of 120 to 150 milligrams per kilogram induces long-term remission in roughly 85% of clients. Because isotretinoin can cause severe birth defects, the United States requires 2 documented negative pregnancy tests before the first prescription, strict use of 2 reliable contraception methods starting 1 month before therapy and continuing until 1 month after the final dose, and monthly verification of pregnancy status through a federally mandated isotretinoin safety registry. Laboratory surveillance is equally crucial. Baseline and monthly panels track alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, and fasting triglycerides. With therapy, paused if triglycerides climb above 800 milligrams per deciliter, or liver enzymes exceed 3 times the upper limit of normal. Common reversible effects: colitis, dry skin, fragile nails, epistaxis, conjunctivitis, photosensitivity, and achy joints require proactive coaching on liberal petroleum-based lip balm, non-comedogenic moisturizers, artificial tears, and broad-spectrum ultraviolet A and ultraviolet B sun protection. Clients who participate in high-intensity sports may notice mild muscle soreness and small rises in creatine kinase. Encouraging rest days and hydration usually keeps them comfortable. Mood changes, although uncommon, deserve honest discussion. Any emerging depression or suicidal thought warrants immediate evaluation, and if necessary, dose adjustment or discontinuation. Shifting briefly to the other options, valacyclovir is an antiviral that halts herpes simplex and varicella zoster replication, but does nothing for sebaceous activity or follicular keratinization. Terbinafine disrupts fungal cell wall synthesis and shines in onychomycosis and ringworm, yet leaves acne untouched. Rifampin blocks bacterial ribonucleic acid polymerase and is reserved for tuberculosis and some resistant staphylococcal infections. It neither targets Cutibacterium acnes, biofilms in follicles, nor modulates sebum production, and routine monotherapy invites rapid resistance along with the well-known risk of hepatotoxicity and orange-tinged body fluids. Putting it all together, isotretinoin is the logical escalation after combination. Topical therapy and an adequate course of oral antibiotics have fallen short, and the nurse's role is to reinforce contraceptive vigilance, monitor laboratory trends, manage predictable dryness, and keep communication lines open for any physical or emotional concerns as this powerful drug guides the skin toward lasting clarity. Switching focus back to safe prescribing, let us zoom in on question 5. A 21-year-old woman with disfiguring nodulocystic acne has completed the iPledge prescriber counseling and is eager to begin isotretinoin therapy. Before the first prescription can be dispensed, which a laboratory test result must the nurse verify as a strict prerequisite. Pause for a quick mental scan of required labs, then consider the possibilities. Option A, serum thyroid stimulating hormone level. Option B, quantitative serum beta, human chorionic gonadotropin test. Option C, erythrocyte sedimentation rate. Option D, serum magnesium concentration. Keep timing in mind, because the single result that opens the door to treatment is option B, quantitative serum beta human chorionic gonadotropin test. Now, let us unpack why this one carries absolute priority and why the others do not. Isotretinoin is a systemic retinoid with a well-established record of causing devastating birth defects, including craniofacial, cardiac, and central nervous system abnormalities, if exposure occurs during pregnancy. Federal iPledge regulations therefore mandate 2 documented negative pregnancy tests, one drawn in a certified laboratory immediately before the first prescription, and a second obtained in the prescriber's office just before counseling is finalized, followed by monthly negatives during therapy and for 1 month after the last dose. The program's electronic authorization will not release the prescription until these results are logged, making the beta human chorionic gonadotropin test non-negotiable. In contrast, a serum thyroid-stimulating hormone level can help rule out hypothyroidism, which occasionally produces acne-form eruptions, yet abnormal thyroid activity neither increases isotretinoin toxicity nor endangers fetal development directly. So it is considered optional and can be addressed later if clinical signs point that way. The erythrocyte sedimentation rate is a broad marker of inflammation, but offers no actionable data for isotretinoin dosing or monitoring, so ordering it would add cost without protecting the client. Serum magnesium concentration becomes relevant mainly for individuals on proton pump inhibitors, diuretics, or certain chemotherapeutic agents. Isotretinoin does not disturb magnesium balance, making routine screening unnecessary. By confirming the quantitative beta-human chorionic gonadotropin level first, the nurse safeguards both client and future fetus and ensures the pharmacy can lawfully dispense a medication that, while often life-changing for severe acne, carries a responsibility for vigilant teratogenic risk management every single month of therapy. Shining the spotlight on safe medication groundwork, here comes question 6. A 23-year-old client with recalcitrant nodulocystic acne has completed baseline liver function tests and 2 documented negative pregnancy tests. Before dispensing the first 30-day supply of isotretinoin, which additional laboratory study must the nurse confirm is on file to ensure safe initiation of therapy? Take a second to scan the possibilities as we lay them out. Option A, fasting lipid panel, total cholesterol and triglycerides. Option B, serum uric acid level. Option C, erythrocyte sedimentation rate. Option D, serum ferritin concentration. Now, lock in your choice, because the laboratory value that truly protects this client is option A, fasting lipid panel, total cholesterol and triglycerides. Here is the deep dive that makes this decision crystal clear. Isotretinoin upregulates hepatic synthesis of very low-density lipoproteins and simultaneously downregulates lipoprotein lipase activity, slowing peripheral clearance of circulating triglycerides. That dual hit can push triglyceride levels above 800 milligrams per deciliter in as many as 45% of clients, setting the stage for acute pancreatitis and, over time, cardiovascular disease. Establishing a fasting baseline of total cholesterol, high-density and low-density lipoproteins, and especially triglycerides, gives the team a reference point for the mandatory monthly checks and allows clinicians to intervene early through dietary counseling, omega-3 supplementation, or dose adjustment if levels start to climb. By contrast, serum uric acid detects gout risk and monitors drugs like pyrazinamide or ethambutol. Isotretinoin does not perturb purine catabolism, so measuring it adds no safety value here. Erythrocyte sedimentation rate flags generalized inflammation, but has no predictive power for isotretinoin-related hepatotoxicity, dyslipidemia, or mucocutaneous effects, so guidelines exclude it from baseline workups. Serum ferritin tracks iron stores and acute phase responses, yet isotretinoin neither chelates iron nor triggers iron overload or deficiency, making ferritin surveillance unnecessary. In short, confirming the fasting lipid panel before that first blister pack leaves the pharmacy arms the healthcare team with the data needed to keep triglycerides in check, prevent pancreatitis, and steer this powerful retinoid course safely toward clear skin and restored confidence. Pause for a second. Let's talk about your NCLEX prep. If you're looking for the most complete guide out there, this is it. 100 hours of animated NCLEX content, 500 hours of teaching, 5,000 high-yield questions, 500 NGN-style case study, and 15 exam-style mocks. Plus, you get a bonus NCLEX ebook and access for 1 full year. Get 70% off today. Limited time deal. The link's in the description. Join the thousands who are already passing. Here comes another high-stakes checkpoint before diving into biologic therapy. Question 7. A client with severe plaque psoriasis is scheduled to begin the biologic agent adalimumab. Before the first injection, which laboratory or diagnostic screening must the nurse verify is complete to reduce the risk of a life-threatening complication? Take a beat while we line up the contenders. Option A, baseline serum urate concentration. Option B, interferon gamma release assay for latent tuberculosis. Option C, hepatitis A immunoglobulin, M antibody titer. Option D, total serum calcium level. Focus on the screening that guards against a silent yet deadly infection, because the essential test is option B, interferon gamma release assay for latent tuberculosis. Now, let us peel back the layers and explore every detail. Adalimumab is a monoclonal antibody that neutralizes tumor necrosis factor alpha, a cytokine critical for maintaining the granulomatous walls that keep Mycobacterium tuberculosis dormant. Once tumor necrosis factor alpha is blocked, those granulomas crumble, allowing quiescent bacilli to disseminate rapidly and produce miliary or extrapulmonary disease that can be fatal within weeks. Guidelines therefore require documentation of a negative interferon gamma release assay, or a tuberculin skin test, obtained within the preceding 3 months. If the screen is positive, latent tuberculosis treatment with either 9 months of isoniazid or 4 months of rifampin must begin, and most prescribers delay adalimumab until at least 1 month of chemoprophylaxis has been completed. Annual tuberculosis retesting follows, because continued tumor necrosis factor alpha suppression sustains the reactivation risk. Switching to the distractors, a serum urate level matters for gout and for medications that raise uric acid, but adalimumab neither alters purine metabolism nor puts the kidneys at risk for urate stones, so the result would not influence therapy. Hepatitis. Immunoglobulin M indicates an acute self-limited viral infection that confers lifelong immunity after recovery and seldom reactivates. The biologic-related hepatic threat is actually hepatitis B, not hepatitis A, so this assay would not mitigate the danger we are trying to avoid. Total serum calcium guides management of parathyroid disorders and malignancy-related hypercalcemia. Yet adalimumab does not disturb calcium homeostasis, and knowing the value would not change dosing, timing, or monitoring of the biologic. Verifying a current negative tuberculosis screen, initiating appropriate prophylaxis when needed, and documenting follow-up plans allow the nurse to move forward with confidence. Knowing the client's immune defenses are ready for tumor necrosis factor alpha blockade without opening the door to a preventable, life-threatening infection. Rolling out our next case, question number 8 drops us into the pediatric clinic with a wriggling rash mystery. Question 8. A 3-year-old child is diagnosed with scabies after the entire family develops intense nocturnal pruritus. Which prescription, if written by the primary healthcare provider, should the nurse recognize as the evidence-based first-line therapy for this pediatric client? Picture the possibilities as I read them aloud. Option A, permethrin. 5% cream applied from neck to toes once and repeated in 7 days. Option B, lindane lotion applied for 8 hours then rinsed off. Option C, ivermectin 300 micrograms per kilogram orally single dose. Option D, salicylic acid 10% ointment applied nightly for 5 days. Time to zero in on the gold standard order. The safest and most effective choice is option A, permethrin, 5% cream applied from neck to toes once and repeated in 7 days. Here is why that option stands above the rest, and stay tuned because these details are testable. Permethrin is a synthetic pyrethroid that paralyzes Sarcoptes scabiei by blocking sodium flow through mite nerve membranes, rapidly killing both adults and eggs. Absorption through intact human skin is negligible, which is why guidelines endorse it for infants as young as 2 months old. A second application 1 week later catches newly hatched larvae before they mature, breaking the life cycle and slamming the door on reinfestation. By contrast, lindane can trigger neurotoxicity and documented seizures in young children when even mildly overused, relegating it to last-ditch status after safer agents fail. Oral ivermectin works wonders for heavy-crusted scabies and institutional outbreaks. Yet current approval requires a body weight of at least 15 kilograms, and caution persists about rare encephalopathy in toddlers whose blood-brain barriers are still maturing. So it is not first line for a typical 3-year-old. Salicylic acid is purely keratolytic, great for warts, useless against mites, and would only inflame already irritated skin while infestation smolders on. Remember, successful management extends beyond the tube. Instruct families to launder bedding, clothing, and plush toys in water hotter than 50 degrees Celsius and to tumble dry on high heat, or seal non-washables in plastic for 72 hours so starving mites die off. Warn that itching can linger up to 4 weeks because the immune system keeps reacting to dead mite proteins, and emphasize treating all close contacts, plus repeating permethrin exactly 1 week later to guarantee every last critter is gone. Gliding into our next pharmacology pit stop, question 9. An older adult is starting oral terbinafine for onychomycosis of several toenails. Which client-reported symptom should the nurse recognize as a possible manifestation of a serious adverse drug reaction requiring immediate evaluation? Let the options roll out for quick comparison. Option A, persistent ringing in the ears. Option B, diffuse photosensitivity, rash after sun exposure. Option C, sudden bilateral ankle edema. Option D, dark urine accompanied by pale stools and right upper quadrant pain. Take a moment to match each complaint with the drug's known toxicities, because the red flag warning sign is option D, dark urine accompanied by pale stools and right upper quadrant pain. Ready to journey beneath the surface? Let us uncover the essentials together. Terbinafine undergoes extensive hepatic metabolism through multiple cytochrome P450 pathways. In genetically susceptible individuals, reactive intermediates provoke cholestatic or mixed hepatocellular cholestatic injury that often emerges within 6 to 8 weeks of therapy. When bile flow stalls, conjugated bilirubin backs up into the bloodstream, spills into the urine, and turns it tea-colored, while the absence of bile pigments in the intestine produces acholic, putty-colored stools. Stretching or inflammation of Glisson's capsule around the liver registers as a dull ache in the right upper quadrant. These three clues together signal evolving liver injury that can accelerate to fulminant hepatic failure if terbinafine is not stopped promptly and supportive care begun. Swinging the spotlight to the other choices, persistent ringing in the ears points toward autotoxic agents such as aminoglycosides, loop diuretics, or high-dose salicylates. Terbinafine has no established link to cochlear damage, so therapy usually continues while other causes are explored. A photosensitivity rash fits classic culprits like tetracyclines, thiazide diuretics, and psoralens. Terbinafine's molecular structure does not appreciably absorb ultraviolet wavelengths, making photodermatitis vanishingly rare. Sudden ankle edema is a hallmark of calcium channel blockers, thiazolidinediones, or fluid-retaining states like heart failure. Terbinafine neither alters capillary hydrostatic pressure nor impairs renal sodium handling. So swollen ankles would steer the workup toward cardiovascular or renal explanations rather than hepatic toxicity. By teaching clients to report dark urine, pale stools, jaundice, upper abdominal pain, or unexplained fatigue at once, and by checking baseline and 6-week liver enzymes, the nurse creates a safety net that catches rare but potentially fatal terbinafine hepatotoxicity long before it can cause irreversible harm. Flowing right along, our upcoming skin scenario awaits. Here is question 10. A college student with inflammatory acne has been using topical tretinoin 0.05% cream nightly. Which over-the-counter product should the nurse instruct the client not to apply concurrently because it chemically inactivates tretinoin? Now, let us line up the contenders so you can weigh the science behind each one. Option A water-based moisturizer applied in the morning. Option B, doxycycline 1% topical gel. Option C, benzoyl peroxide 2.5% wash used at bedtime. Option D, clindamycin phosphate 1% solution applied at noon. Take a breath and think through oxidation reduction chemistry, because the combination that sabotages tretinoin's efficacy is option C, benzoyl peroxide 2.5% wash used at bedtime. Let us roll up our sleeves and examine the heart of the matter. Tretinoin, a retinoic acid derivative, relies on its intact conjugated double bond system to bind nuclear retinoic acid receptors, normalize keratinocyte desquamation, and boost collagen synthesis. Benzoyl peroxide, meanwhile, is a potent oxidizing agent that generates free radicals to attack bacterial proteins in the follicle. When benzoyl peroxide sits on the skin alongside tretinoin, those radicals oxidize the retinoid's double bonds, converting active all-trans retinoic acid into inert metabolites within minutes. The result is an almost total loss of comedolytic power and a frustrated client who perceives treatment failure. Fortunately, staggering application solves the problem. Benzoyl peroxide in the morning and tretinoin strictly at night preserves both mechanisms without chemical clash. Turning briefly to the other options, a water-based moisturizer simply forms an emollient film, restoring the stratum corneum barrier and actually lowering irritation from tretinoin without altering its structure or receptor affinity. So it is encouraged, not forbidden. Topical doxycycline delivers anti-inflammatory action by dampening neutrophil chemotaxis and matrix metalloproteinase activity, and has no redox interaction with tretinoin. Indeed, many clinicians layer the two in moderate inflammatory acne regimens. Clindamycin phosphate solution inhibits Cutibacterium acnes protein synthesis and pairs nicely with tretinoin because the retinoid increases follicular permeability. The two coexist stably in several commercial combination gels, proving their compatibility. By coaching the student to separate benzoyl peroxide and tretinoin by at least 8 to 12 hours, apply only a pea-sized dab of tretinoin after gentle cleansing, and expect a transient flare or purge during the first month, the nurse ensures maximal therapeutic synergy and keeps adherence on track for the clear skin payoff that follows diligent long-term use. Flowing straight into burn care decision-making, question 11. A client with a full-thickness burn to the calf is allergic to sulfonamides. Which topical antimicrobial dressing should the nurse expect to be ordered instead of silver sulfadiazine? Consider each alternative carefully as we line them up. Option A, mafenide acetate. Sulfamelon cream applied twice daily. Option B, bacitracin ointment applied under a non-adherent dressing. Option C, silver-impregnated hydrofiber dressing. Option D, silver sulfadiazine cream applied once daily. Pause and match each product with both its chemical backbone and microbial spectrum, because the most appropriate order for a client who cannot tolerate sulfa compounds is option B, bacitracin ointment applied under a non-adherent dressing. Let us unpack why this choice rises to the top while the others fall short. Bacitracin is a cyclic polypeptide that interrupts cell wall formation in gram-positive bacteria, such as Streptococcus species and non-resistant Staphylococcus aureus. It contains no sulfonamide moiety, so cross-reactivity with sulfa allergy is essentially non-existent. The petrolatum base keeps the wound bed moist, which promotes epithelial cell migration across the defect. And the translucent layer makes frequent wound inspection easy, an advantage when monitoring for early cellulitis in an outpatient setting. Although its gram-negative coverage is limited, the risk of pseudomonas is low in a small isolated burn on the lower extremity, and systemic therapy can be added promptly if surveillance cultures or clinical signs point to broader infection. Turning to the alternatives, mafenide shares the sulfonamide backbone with silver sulfadiazine and often cross-reacts. It penetrates a char well and covers pseudomonas, but causes intense stinging and can induce metabolic acidosis by inhibiting carbonic anhydrase, making it both painful and unsafe for this allergic client. Silver-impregnated hydrofiber dressings do release ionic silver on a non-sulfa carrier and provide broad gram-positive and gram-negative activity. Yet availability and cost can limit their use on general units, and the question points toward a readily stocked replacement rather than a specialty product that may require pharmacy approval. Silver sulfadiazine, of course, is off the table entirely because the sulfadiazine component can provoke reactions ranging from morbilliform rash to life-threatening anaphylaxis in anyone with a documented sulfonamide allergy. By selecting bacitracin, the nurse ensures antimicrobial coverage, compatible with the allergy profile, maintains a healing-friendly moisture balance, and enables close visual assessment so any emerging gram-negative threat can be detected and treated without delay. Sliding effortlessly into another real-world nursing scenario with question 12. A client has used high-potency clobetasol propionate ointment over 20% of body surface area for 6 weeks to control an eczematous flare. Which systemic complication should the nurse assess for because of prolonged therapy on large skin surfaces? Now, steady your focus as we parade the possibilities. Option A, hypothalamic pituitary adrenal axis suppression. Option B, hyperkalemia. Option C, agranulocytosis. Option D, sinus bradycardia. Take a breath and think about how much corticosteroid can soak through the skin when it blankets a fifth of the body, because the clear red flag outcome is Option A, hypothalamic pituitary adrenal axis suppression. Join me as we plunge into the core concepts step by step. Potent topical corticosteroids such as clobetasol readily penetrate areas with thin stratum corneum, axilla, groin, eyelids, and absorption climbs even higher when ointments are applied under clothing that traps heat and moisture. Over weeks, enough drug reaches the bloodstream to create supraphysiologic glucocorticoid levels that feed back to the hypothalamus and anterior pituitary, shutting down corticotropin-releasing hormone and adrenocorticotropic hormone secretion. The adrenal cortex idles, cortisol output plummets, and the client risks secondary adrenal insufficiency. Clinically, that can look like early morning fatigue, salt craving, orthostatic dizziness, or, in the worst case, hypotensive crisis if the ointment is stopped abruptly, or a stressor such as infection strikes. A morning serum cortisol below 5 micrograms per deciliter, or a flat response to casintropin confirms suppression and cues a slow taper with physiologic oral hydrocortisone cover. Switching briefly to the distractors, glucocorticoids enhance renal potassium excretion, so prolonged exposure trends toward hypokalemia, not hyperkalemia. A rising potassium level would send you hunting for renal failure or angiotensin-converting enzyme inhibitors rather than blaming the ointment. Agranulocytosis is the domain of medications like clozapine and propylthiouracil. Systemic steroids actually bump neutrophil counts by demarginating cells from vessel walls, so white cell wipeout is not on the clobetasol risk list. Sinus bradycardia does not fit either. Excess glucocorticoid typically nudges blood pressure and heart rate upward through sodium retention and sensitization to catecholamines. A slow pulse would more likely track back to beta blockers, calcium channel blockers, or intrinsic conduction disease. In practice, nurses can protect clients by reserving ultra-potent steroids for short pulses, no more than 2 weeks on thin skin or 4 weeks on thick plaques. Then stepping down potency, tapering slowly to let the adrenal glands wake up, watching for stria or skin thinning, and educating clients never to halt high-dose topical therapy overnight without guidance, thereby dodging an avoidable adrenal crash while still reaping eczema relief. Hold up! Are you feeling confident about the NCLEX? If not, you'll want to check out the complete NCLEX Review online course. It's packed with 100 hours of animated videos, 500 hours of deep content, 5,000 practice questions, 500 NGN-style case study, and 15 full mock exams. There's also a full NCLEX ebook included, with a 1-year access window. And right now, it's available for 70% off, but only for a short time. Click the link in the description and join the thousands of students who've already passed. Shifting our lens to kidney-conscious antiviral care. Question 13. An immunocompromised client with a herpes zoster eruption is ordered intravenous acyclovir. Baseline creatinine clearance is 30 milliliters per minute. Which adjustment should the nurse expect the pharmacist to make to reduce the risk of crystal-induced nephropathy? Let us weigh the pharmacist's possible moves. Option A, increase the infusion rate to deliver each dose in 30 minutes. Option B, add oral probenecid to block renal tubular secretion. Option C, administer the standard dose every 8 hours without alteration. Option D, reduce the dose or extend the dosing interval based on renal function. Now, zeroing in on the strategy that actually protects those nephrons, the correct choice is option D, reduce the dose or extend the dosing interval based on renal function. Together, we will navigate the depths of this topic for complete clarity. Acyclovir is eliminated almost entirely by glomerular filtration and active tubular secretion. When glomerular filtration rate falls, unmetabolized drug lingers in the nephron, and its low solubility means it can precipitate as needle-shaped crystals that obstruct tubules and trigger acute kidney injury. Dose adjustment tables therefore advise having the usual dose or stretching the interval to every 12 to 24 hours once creatinine clearance dips below 50 milliliters per minute, a plan that maintains antiviral efficacy while preventing intratubular supersaturation. Adequate hydration, about 500 milliliters of isotonic saline before and after each infusion, along with a slow drip lasting at least 60 minutes, further dilutes urinary drug concentration and keeps flow brisk, denying crystals a foothold. Accelerating the infusion, as in option A, would spike tubular levels and hasten precipitation. Adding probenecid, as in option B, blocks organic acid transporters, deliberately raising serum and tubular acyclovir, thereby magnifying both nephrotoxicity and potential neurotoxicity, such as tremor or confusion. Sticking with full Q8-hour dosing, as in option C, ignores impaired clearance altogether and virtually guarantees accumulation. By anticipating renal-based dose reduction, ensuring generous fluids, infusing slowly, and monitoring serum creatinine every 48 hours, The care team shields the kidneys while giving acyclovir the time it needs to control the viral threat, gliding smoothly into another clinical pivot with question 14. A client with chronic atopic dermatitis is prescribed topical pimecrolimus cream for lesions on the face and neck. Which statement by the nurse accurately explains the major advantage of pimecrolimus over high-potency topical corticosteroids? Steady your focus while we set out the possibilities. Option A. It has strong antifungal properties that treat concomitant infections. Option B. It produces systemic immunosuppression that clears the rash faster. Option C. It does not cause skin thinning even with long-term use. Option D. It works best when applied under an occlusive dressing. Now, lock in the response that truly highlights why dermatologists reach for this agent on delicate skin. The correct choice is option C. It does not cause skin thinning even with long-term use. Here is the reasoning unpacked step by step so it feels intuitive rather than memorized. Pimecrolimus is a topical calcineurin inhibitor that prevents activation of T lymphocytes and subsequent cytokine release, yet it leaves dermal fibroblasts untouched. So collagen synthesis and elastic fiber integrity remain intact. Months or even years of use therefore avoid the cutaneous atrophy, telangiectasias, and striae that plague chronic corticosteroid therapy, especially disfiguring on the face. In contrast, calling pimecrolimus antifungal is simply incorrect. Its action is immunomodulatory, not antimicrobial, and fungal overgrowth can actually worsen if local immunity is suppressed, meaning clients sometimes need a separate antifungal when Candida appears. Claiming that pimecrolimus works by systemic immunosuppression is equally off base, because less than 1% of the applied dose reaches the bloodstream, and clinical trials show efficacy on par with mid-potency steroids, not dramatically faster clearance. Advising occlusive dressing would defeat its safety advantage, as occlusion boosts percutaneous absorption, intensifies the transient burning that about 1/3 of users feel during the first week, and could theoretically raise systemic exposure. By explaining that pimecrolimus safeguards facial and flexural skin from steroid-induced thinning while still calming inflammation, the nurse sets accurate expectations, encourages diligent sunscreen use to offset any ultraviolet-related risk, and reassures clients that the medication can be a long-term friend where corticosteroids must be short-term guests. Continuing our stride, the next dermatologic mystery is ready for discovery. Question 15. A client with post-herpetic neuralgia is prescribed lidocaine 5% topical patches. Which instruction should the nurse provide to ensure safe and effective use? Now, focus as we lay out the possibilities. Option A. Apply the patch to intact skin over the painful area for up to 12 hours. Then remove it for at least 12 hours before applying a new one. Option B. You may keep the patch on continuously for 24 hours a day to maintain pain relief. Option C. Cut the patch into small pieces to fit around bony prominences. Option D. Place a heating pad over the patch to enhance absorption if pain increases. Taking all pharmacokinetic facts into account, the guidance that keeps plasma levels in the therapeutic window is Option A. Apply the patch to intact skin over the painful area for up to 12 hours, then remove it for at least 12 hours before applying a new one. Come along as we dissect the details and transform complexity into understanding. Each lidocaine patch contains approximately 700 milligrams of drug embedded in a controlled-release matrix. When worn for no more than 12 hours, dermal uptake is slow, systemic absorption remains minimal, and analgesia is confined to the epidermal and dermal nerve endings that generate neuropathic pain. After 12 hours, however, the stratum corneum becomes saturated and lidocaine begins to diffuse more rapidly into the circulation. If the patch stays on, blood concentrations can climb into a range that affects voltage-gated sodium channels in the central nervous system and myocardium, potentially producing perioral numbness, metallic taste, tinnitus, tremor, seizures, or conduction delays. The 12-on, 12-off cycle gives skin and plasma reservoirs time to clear, preventing accumulation while preserving analgesic benefit documented in clinical trials and codified in United States Food and Drug Administration labeling. Wearing the patch around the clock, as suggested in Option B, doubles exposure time and markedly raises toxicity risk, especially in older adults whose dermal barrier is thin and whose hepatic clearance may be slower. Altering the patch by cutting it, as in Option C, disrupts the uniform polymer matrix that meter doses lidocaine. Edges can leak drug unpredictably, leading to hotspots of absorption or premature exhaustion of the remaining patch, so manufacturers forbid trimming. Applying external heat, as in option D, boosts cutaneous blood flow and accelerates drug flux into the bloodstream. Case reports describe convulsions and cardiovascular collapse when heating pads or electric blankets were used over local anesthetic patches, making this practice unequivocally unsafe. Therefore, instruct clients to press up to 3 whole patches onto clean, intact skin covering the painful dermatomes. Remove them after 12 hours. Fold the used patches adhesive to prevent accidental contact by children or pets. And keep the treated area cool, never warm, to maintain both comfort and safety. And that brings our pharmacology of the integumentary system session to a close. Another boost toward nailing your NCLEX and stepping confidently into practice. We release fresh, high-yield nursing content every single day, so weave these quick sessions into your routine and watch your readiness soar. Follow the channel, keep coming back, and join us for the next deep dive. Your success story is just a video away.